welcome everybody to the first Adult Health and Social Care Committee of the new municipal year. Before I just start the actual business, I'd actually like to just say thank you to my predecessor, Councillor Bill Armour, for all the hard work that he did last year. If we can just go through and just introduce ourselves. Councillor Bamford, if you wouldn't mind starting.
Councillor Tim Bamford, Denbydale Councillor.
Councillor Alison Munro, Almondbury Ward. Thank you.
Councillor Beverley Addy, Combe Valley Ward.
Kim Taylor, Voluntary Co-op Tea.
Helen Clare, Voluntary Co-op Tea.
Thank you. Are there any apologies?
No apologies received, Chair.
And for those that were at the last meeting, have they read the minutes and agreed that they are a true record? Yes. Yep, thank you. Are there any declarations of interest?
None received, Chair.
And everything today will be done in public. Do we have any deputations or petitions?
None received, Chair.
Thank you. If we can then move on to the presentation from the Care Quality Commission. Thank you. And if you'd like to introduce yourselves, please.
Yeah, hi, good afternoon, everyone. I'm Jo Okinshaw. I'm an operations manager with the Care Quality Commission, working in Kirklees, Calderdale and Wakefield. I've got my colleague with me today who also works with myself in the same area. I'll let her introduce herself.
Thanks, Jo. Hello, everybody. My name's Melanie Kilgour and I'm an operations manager working alongside Jo.
Thanks, Melanie. Okay, so we're just going to, I suppose before we start our presentation today, I'd just like to say that you're probably already aware that our Chief Executive Officer, Ian Trenchholm, has recently stepped down from his position. So we currently have an interim Chief Exec working at the Care Quality Commission. So what we're presenting today is how we currently are working in the new model. But I suppose what I want to say is that those things, some of those things may change as we respond to feedback we've been receiving from stakeholders. So there'll be some things within that, such as the single assessment framework and the regulatory platform, that probably will not change, but anything else may change as we move into these next few months. So Melanie's going to start today with a bit of a presentation about our current model, the single assessment framework, and then I can give a little bit of an overview regarding Kirklees and some of the providers that we've got in Kirklees at the moment. So I'll hand over to Melanie.
Thanks, Jo. Okay, so I'm not sure if you can all see the slide, so I'm just going to speak to them as we go through. So in terms of starting our new assessment process, so this began last year, towards the back end of last year. It was rolled out gradually across the country. So we started with a really small group of providers, looking at some really small planned assessments, what we would have called inspections in the past. And we used that learning to help us develop the approach as it rolled out gradually across the country. So in December, we worked with a few local authority areas, Milton Keynes, Luton, and rolled the single assessment framework out to all providers across the South region. And then gradually we moved further north and we got to us in early February. So Jo and I moved into our new teams last year, and these are multidisciplinary teams. So Jo and I work with a team of inspectors and assessors covering all specialisms, so adult social care, hospitals, secondary care, mental health and primary care. And we manage a multidisciplinary team, and our role is multidisciplinary as well. So although we were already in these teams, we hadn't started using the single assessment framework until February this year, and beginning to use our regulatory platform, which is our new as it sounds, it's the platform that we use for all of our information and assessments. We've also started doing some trust well-led inspections. So in your neighbouring area in Bradford, we are in the process at the moment of inspecting the trust, and we're using our new framework and system to assess applications to register new services. That's very new. That's just starting to roll out now. As part of the assessment approach, we've been really closely as an organisation listening to feedback from providers. Joe's already alluded to that at the start. Feedback from providers, from stakeholders about what is and isn't working. So it's very much an iterative process and making changes as we go. And we're trying to make sure that everyone's kept up to date, but appreciate that there are lots and lots of changes. So our website is a good point of reference for keeping up to date on that. So just going through some of the differences from our previous model, and a lot of it's around gathering evidence. So in the past, we would have carried out an inspection and gathered information at that particular time, very focused on information that we gather sort of on site when we're doing observations and asking for what we would call a pre-inspection return. We're making far more use of information other than that. Feedback from patients and service users is crucial to, so they can share and we can learn from their people's experience. And inspections are not our only tool, so a lot of the work we can do remotely by speaking with staff, speaking with patients, to build up our picture and understanding of a service. In the past, we had a frequency chart, if you like. So if you were rated a certain rating, we would come back out and re-inspect within a certain time frame. That's no longer the case. So we can collect and review evidence or information at any time to allow us to review our understanding and rating of a particular service. Assessing quality, I've more or less said that. So we'll be making judgments, or the aim is in the future to make judgments about quality more regularly instead of only after an inspection. And again, using evidence from a variety of sources and looking at a number of quality statements. I'll come on to talk about quality statements in a moment. They are definitely more structured and transparent. So there's a scoring system, which again is part of our published assessment, and it's really clear for providers where there are areas where they've performed really well and where they haven't, and they can use that to benchmark. A little bit of background on how the process itself will work. So all of the guidance is online. We've run several of these local sessions for adult social care providers, primary care, so just to sort of run through the process to alleviate some of the myths for the providers. So what we've said is that all the guidance is online, and we will continually update it and refine it based on the changes that we've said that we will make. The new framework does retain our 5 key questions, so whether an organisation is safe, effective, caring, well-led and responsive, and the 4-point rating, so outstanding, or we'll start with the best first. Outstanding, good, requires improvement, and inadequate, we are keeping those. And we are now assessing against quality statements, and the quality statements are the bit that replaces our former key lines of inquiry. The types of evidence that we consider, so underneath each quality statement there are a number of evidence categories, 6 in most cases, and in each of the different sectors, so for adult social care, for example, for primary care, we will very clearly state which evidence categories we will look at as part of under each quality statement. I'm just getting the terminology right. As we've done in the past, our assessments could be responsive, so where we've received information of concern, or planned. So whilst we don't have an inspection schedule, as I've just alluded to, there will be, say, a service that we haven't been to for a number of years where we want to go back, or if we're doing some thematic work where the inspections would be more planned. In both cases, though, we'll be flexible. So say if we're doing a responsive and we're looking at some areas of risk, when we get there, we find there are other issues, then we will open that and expand that assessment. And same if we're doing a planned assessment in exactly the same way. So during the assessment process, thinking about how we engage with providers, we will continue to apply existing rules where we are announcing. So in some sectors we announce inspections, in some we don't, and we'll continue with that. If we deviate from that, we would have an internal decision review and record our rationale for whether we do or we don't give notice of an inspection. And once we've done that, once we've started, we would let the providers know that the assessment is starting, and we may continue to ask them for some information ahead of the assessment or any on-site activity. We may not need to carry out a site visit, as I've mentioned before, so some of this could all be done remotely. I think that's some of the great learning that we've all taken from the past few years around working remotely. We're able to do that. We have teams supporting us, so we have experts by experience who can go out. We have a medicines team, medicine specialist that can go out, and we have our national professional advisors and clinical staff who can all go out and support. So it isn't just an inspector going out. We will continue to give feedback at the end of an assessment. That may be slightly afterwards, because if you think we need to come away and review the information that we found, but we would always give feedback to the provider. And if we have significant concerns, then we would highlight with local authorities and partners to make sure that they're aware and can take their own action as necessary. Sort of the new bit. So we're going to give a score. So we don't, although they're going to be the ratings, sitting underneath the ratings, there are scores. So we will give a score for each evidence category that's part of the assessment that we're undertaking. All evidence categories and quality statements are weighted equally, so that one doesn't count for more than the other. It's very much a straightforward comparison. And the scores, if you've got the slides, I'll not read it out, but the scores go from 4 to 1, where 4 is that the evidence shows an exceptional standard of care, and 1 is where evidence would show significant shortfalls. The scores are then combined to give a total score for the relevant key question, which then in turn would result in the rating. At the moment, we're going to publish the ratings, but the scores will be published in future. It's quite simple in the end, but it's quite complicated to understand, and I couldn't do it justice. But that we have put a link into a video if you're interested to look at the scoring. There's so many different connotations of what the numbers add up to and what it means, and so for the detail, it's worth a watch. Certainly to get a bit more of an understanding. So as I've said, we use the scoring system to produce the rating, and as in the past, we would issue a draft report to the providers, and they will have a chance to submit a factual accuracy submission, which we would consider as we always have. We would then publish, and instead of it being what you may have seen in the past, a PDF document that you can download, it will all be online in a web content, and if you look on our website for some of the newer reports that have been published, it's quite clear, and it sets out the sections that we've looked at, the quality statements and the narrative underneath that. And if any ratings change, obviously that will be published alongside. If once we've published the report, the provider feels that the ratings are incorrect and want to challenge the rating, then they can continue to do so through our ratings appeal process. So that, again, that procedure has been in place for a long time, and that will continue. So providers will still have the opportunity to do that. Just to bear in mind, if they do, that is an appeal to make sure that we followed process. So it's very clear on our website, the remit for considering challenges to ratings. We've put another slide in around how we reach a rating. It sort of probably explains it better than I did before. So at the top, you've got a quality statement, one of the quality statements, and as we talked about earlier, there is required evidence categories. So for the infection prevention and control, we would consider 4 of the 6 evidence categories. So people's experience, feedback from staff and leaders, observations and processes. And then underneath that, it would give an example of the types of information or observations that we would look at as part of that. So you can see how it all builds up from very detailed information that we get from these assessments. In terms of how we have and will continue to implement the changes, so we didn't release everything at once. And for example, where we were undertaking enforcement work, that was still sitting in our former system. It's only just moved over to our regulatory platform. Similarly with our registration colleagues, they're a little bit further behind in the process. So every move is being considered and an improvement's being made before we do so. So as it says, we want to learn as we go, starting small, and again, that's why we started in one of the regions in the south network, and gradually rolled out across the country to sort of measure the impact and do a bit of a sense check, really. Feedback has been massive and will continue to be key. I think it's only once we're all using this system, working together collaboratively, that we're going to get the feedback about how it's working and where improvements could be made. And what we've said for providers is we'll be clear about every step, what it means for you. And that, as I've said, if there is a really good section on our website on, step by step, what the changes are, what it means for providers. And there's all still the old guidance there in terms of how they need to meet the regulations. So there's a huge amount of information and a lot of engagement. As part of, in the last slide in the pack, we've just put some links in. Again, there's a wealth of information there, our bulletins, our social media, some podcasts. There's a lot of videos on YouTube as well, a lot of webinars that have sort of been published over the last, I would say, 6 months. There's a lot of guidance out there. Yeah, so that's all available for you. So I hope that's just a bit of a brief run through of where we're at. It's still pretty new to us as well, so Joe and I and our teams are getting to grips with it, and our reports are starting to come out now and go out for factual accuracy. We're busy across all sectors. So on that, I'll hand over to you, Joe, for talking a little bit about where we are in terms of each sector. Thank you.
Okay, so we shared the slides with yourself regarding our provider ratings and how they look at this moment in time. So I'm assuming you've got a copy of them and you're able to kind of follow me as I speak. So we've broken down the ratings by the sectors that we regulate. So we've got NHS hospitals, independent healthcare, adult social care, and primary medical services. So they're the different areas that we regulate within our teams, our local teams. So in terms of acute NHS hospitals, we have 2 NHS acute hospitals in Kirklees. We've got Dewsbury and District Hospital, which is part of the Mid Yorkshire Teaching NHS Trust, and Huddersfield Royal Infirmary, which is Calderdale and Huddersfield NHS Foundation Trust. The Mid Yorks requires improvement, and Calderdale and Huddersfield has a rating of good. Calderdale and Huddersfield, I would just add that we haven't inspected that trust for quite some time. So it was 2018 when we last inspected that trust. So when Melanie talked earlier a little bit about the planned inspections, that's probably where that would be picked up moving forward. If we were getting lots of information through, or just might not even be a lot of information but just information through that made us concerned, and we felt that we were seeing a lot of risk in that hospital, we would go out and inspect. We would see that as a risk inspection and would go out and inspect. But if we're not getting that risk through, then those those providers will come through for inspection on the planned inspection list. The Mid Yorks Trust, we inspected them in March 23, so that's a much more up-to-date picture of that trust. So in terms of independent healthcare, we've got a large percent of good services in our independent healthcare, 72.7, so 73% rated as good. The inadequate service, the outstanding service we've got is actually the Forget-Me-Not Children's Hospice, which was quite recently inspected. So that was in January this year. That service does sit within my team, so it was a really lovely inspection for the inspector to be involved in, and particularly with it coming out as that outstanding rating. We've got a couple of services that requires improvement, but as I said earlier, in Maine, we've got good services. In adult social care, we have a lot more providers in the adult social care picture. So we've got 73.5% of adult social care services rated as good, and that if you kind of benchmark that across, we're getting a 70. I think let me just pull that up so I can see it. My slides have gone really small. Is the kind of benchmark is 78.2% as good in adult social care. So I think we're sitting in quite a good position at 73.5%. And primary medical services, again, we've got a lot of good services in primary medical services, and we're sitting at 93.5% of our services rated good in Kirklees. And that's the final slide in relation to how it's looking in Kirklees.
Thank you. I'll open it up for questions. One thing that I was wondering is regarding you saying that normally you would just gather your evidence at the point of an inspection, but from reading the pack that we were actually sent, you're actually now saying that you would be gathering evidence in between inspections, so to say. Would that be because there was a problem, or would it just be something that you would routinely do just to make sure that services were up to standard?
I think that's one of the areas that will evolve. At the moment, it's sort of there's two ways to it. There's one where we might receive information of concern and we would ask the provider for some further information. It could be the complete opposite. It could be that we get some really positive feedback and we think that we could go out on and carry out an assessment or ask for some further information remotely. The plan is that it's meant to be an ongoing system where if the provider thinks we're doing this brilliantly, we want to let CQC know about it, then they will have the opportunity to submit that. Similarly, where say if we've been in and rated a service as inadequate or requires improvement, they could send us an action plan to say this is where we're at now, and we can consider that. That part is still very much in its infancy though, but that's the aim going forward.
Thank you. Councillor Addy?
Thank you, Chair. What's the feedback been like from the areas that you've piloted this in, please? And what areas in the north are you already rolling it out to?
So in terms of the north, we're fully rolled out. That the entire north is working with the regulatory platform and the single assessment framework. So colleagues, I think we have been made aware of colleagues in the south, and there were some initial issues around how the system worked and glitches in, the technical aspect of the system. And there were a lot of changes that were made before it got as far north as it did, if you think of it in that way. In terms of provider feedback, I couldn't say. I haven't really been involved in anything other than speaking with local teams in terms of specific feedback on the system. But I don't know if Joe, you've got anything to add.
I suppose just to mention that we have something called the provider portal as part of our system, where the provider can send us all their information through the provider portal. That's where we kind of pick up their information. There's been some difficulties for some providers using the provider portal, not all providers, but some providers. So it's been a little bit tricky over that. I'd say over the last month or so, there's been lots of fixes happening in the background to try and improve that experience for providers. So we're getting a bit more positive feedback now in terms of the providers using that system, but that was definitely an area that showed some concerns when we first launched it. But as I say, we've been responding to the feedback and putting fixes in place, and things have been gradually improving. We're not 100% there though, I would say that.
Councillor Addy?
What do you see as the key differences and improvements with this new system? And are there any limitations that you've come across, either comparatively to the previous system or just by the necessities of reality, staffing, etc.? But are there any limitations, things that you'd like to improve into the future, and what are the main improvements and key differences?
Go on, what were you going to say?
I was just going to say that the single assessment framework is a really good model, and it's moving forward. Once we've got everything, because we're still in our infancy, we've not been using the model for long, and I think that moving forward, once we've got everything kind of sorted, it will be a really positive move, because it gives a lot of flexibility. It means that further down the line, we should be able to just go into providers, have a look at different things. If we've had a concern through about something, or we've had information through about improvement, we can just go, we can have a look, we can update the system, and we can re-rate if that's what if that's what's appropriate to do. So a lot more flexibility and a streamline and quicker to kind of respond and give a more up-to-date picture. But we're not there yet. We're still I suppose one of the things that has happened is that we have realised that we need to do an up-to-date full assessment of providers before we can start working in that more agile way.
Yeah.
So that means that we need to go and do those full assessments first. So the first round of inspections are going to be bigger inspections, more like the inspections that providers have been used to in the past. But then once we've done that initial inspection, moving forward, it would be a lot more flexible for providers and a lot more agile.
Thanks, Joe. And I would just add, in terms of improvement, I think it's the way that we're structured. I think that's working well in terms of how we work across an area. So Joe and I work really closely together to look at not just Kirklees, but we also cover Wakefield and Calderdale. But then we have a group of managers and a team that covers the whole of West Yorkshire. So we can look at at what's going on across the patch, across all sectors. We have a team of what we call regulatory coordinators that work with us as well, and they're really the gatekeeper to all of the information that's coming into the teams, and they're brilliant at picking up can't speak, trends and themes, and looking to see where the hotspots are. So having that information has at our fingertips has been a real improvement for me in how we're working together as a team.
Thank you. Has anybody... Councillor Addy.
Sorry, just to follow up, one of the concerns I was having there was that it's a bit of one shoe fits all. How have you managed to get this framework to work for everything from adult social care to the hospitals, for example, and that is it going to be flexible enough for that?
Absolutely, and I think that I sort of alluded to it earlier on in terms of the different evidence categories. Although that it's a standard starting, so the single assessment framework is what it says, but within that then there's the flexibility to focus on different areas, focus on different quality statements, and underneath that is the evidence categories, which may suit one sector more than the other. So it allows us to get a full picture without, like you say, just having one size fits all. That isn't necessarily going to fit to every type of assessment that we do. So it's going to be really flexible in those terms.
Thank you. Councillor Munro.
Thank you. So I just want to just some background information on how you decide on the scope of the assessment. First of all, that's my first question. Thanks.
Okay. Do you want me to say that?
Go on.
Yeah. Okay. So I suppose a little bit what I said earlier. For the first round of assessments we need to do that full assessment of all the quality statements. But then moving forward, it would be based on so if we were doing a risk inspection and we were getting some concerns in about something very specific, we'd be looking at the quality statement and the evidence categories for that particular issue. So we could just literally go in and look at that if that's what we wanted to do. So it can be very individualised, dependent on what the issue is. And again, I don't want it to sound like we're just responding to we've just been responding to concerns, because the idea is that if we get through improvements, well, if a provider is sending us information about something that they've improved on, we could just look at the quality statements relating to that and go in and have a look at that.
Thank you. My next question is, so how soon after an inspection or an assessment that was unsatisfactory would you then reassess that establishment? Thanks.
So in the past, we would have had, for example, if a provider was rated as inadequate, we would be back within 6 months. That was the rule, if you like, the scheduling rule. So we don't have that anymore, but it's all down to judgment. So we would obviously give the provider a period of time to submit an action plan to say what they're going to do. We would look at the dates that they've said they're going to comply or improve, and then we would consider that as part of the ongoing information and make a decision about when we go out. So there are not going to be any hard and fast rules. It would be slightly different if we had taken enforcement action. So say we'd issued a warning notice which says you must comply with whichever regulation by X date, then we would go back after that. But in general, it's a bit like what Joe was saying, it's a moving feast. So it's looking at the information that we've got alongside what the provider's telling us, and then making a decision about when's best to go out.
Sorry, thinking about it from a professional perspective, they're going to have that rating, online in the public domain for a considerable time. So I guess the faster that process can happen, the better, really, for everybody concerned. Yeah. Okay. Just one other thing. I noticed you talk about the primary medical services, saying most of them, there's one with outstanding, 61% with good ratings, but there's 25% or something like that who you don't refer to. How have you inspected that 25% yet? Thanks.
I'm not quite sure of the 25%. Sorry, can you just clarify?
Sorry, I'll explain it again. Sorry, you've got primary medical services, 62 primary medical service locations, 61 are GP practices. There's one location which is outstanding. Locations you've got, 3 that are outstanding, but there's no mention of the practices where they've not got a satisfactory rating. So I just wondered, have you already inspected those practices?
We have been out to all practices in the past across Kirklees, and they will all have a rating. They will all have a rating. It may be that some have changed their legal entity, and we would then therefore normally carry out another inspection. But in general, we have been out to them all. I just would like to point out, I suppose, the outstanding rated locations, which is, was brilliant. It's all from a lot of years ago though, and I think they are, when we talk about planned assessments there, we would like to go back to those as well to hopefully see that they are maintaining, that they're outstanding. The requires improvement one in Kirklees is a more recent inspection. That was only last year or earlier this year it was published. But yes, we have been out to them all, and just as a bit of context, before we changed teams, I was the lead for primary medical services across West Yorkshire, so I had oversight. So I'm confident that we have been out to all of those that originally registered. There may be the odd one that we haven't been back to, but it will still have an initial original rating.
Thanks.
Thank you.
Helen.
Hi. If you move into more kind of off-site inspections, how do you ensure that you're always going to capture the voices of the patients, the service users, families and carers? Because obviously things can change, and to me that's really important to get your quality measured. So how is that going to be done when you're mainly focusing on a certain quality statement, or just getting, kind of focused down a little bit more than in the past?
Yeah, absolutely. I think, people's experiences is really at the heart of what we're doing, and it's a real key area which we're sort of putting more emphasis on than we ever did before. So we're proactively seeking feedback, and even if it is a remote assessment or a remote look at some information, we're always going to consider people's feedback. So whether that be the GP practice asking for a list of patients that might be happy to speak with us, or a random selection, we're going to continue with that. And in a recent example, it isn't a Kirklees one, but it's just to give you some context. We inspected a learning disabilities, a home for people with learning disabilities, and we spoke with relatives and got the permission to speak with more. It was a very small place, but we spoke to such a large amount of people, and the inspectors are really keen and advise that we need to get as much feedback to illustrate what we're seeing. Because like you say, you can see what you can see, but we just need that feedback from people. It's a huge commitment from us.
Okay. The last question that I've got is building on the previous question. In terms of if you receive information of concern, how soon before, from when you're notified of that information, from when you receive it to your first intervention or your first involvement, what kind of timescales do we look at?
So I think that's dependent, but obviously if we're getting information of concerns through and it's a safeguarding concern, for example, we have to look at that within 24 hours. So it's a very quick turnaround. So I would say that so in the new way of working, we have inspectors and assessors. So the assessors would be the people that are picking up the notifications and the cases coming through to us, and they do have key performance indicators related to information come through, particularly when it's information of concern that's related to safeguarding.
Okay, thank you.
Hi. So when you're talking about the inspections, and broadly speaking, from what I understand from what you've said, the majority of inspections will be done by information as opposed to a visit. That's sort of the impression I'm getting. So I'm just wondering, would you describe your would you describe CQC now as being more a reactive rather than proactive assessment?
No, I think what I'm trying to say is that looking at information is part of that, and we don't always necessarily have to go out and do a site visit. I think in the past, an inspection was you go out and you do what you do when you gather the information and you see what you see. And I think that is still very much a key part. So the on-site inspection element is still a huge part. I think what we're saying is that we can also consider information that we receive remotely, and assess that as well. And rather than it being you have to wait until your next site visit in order for your ratings to change, it's more that fluid movement of sort of the sharing of information. So absolutely not. I think that the site visits, and all of our inspectors will tell you, that's where that's the main part for them. That's where you're going to see the evidence and get that the inspector feeling when you go on site about a service, and sort of look for that evidence, either positive, or the not so good.
I think also as well, just to add that the model was developed to try and mean that we spent more time on site rather than less time. So it was about maybe us not being there for such a long length of time. So we might not, I suppose in the past we've gone on inspections, we've maybe been there 3 days. The new model supports us to go more regular, but for shorter periods of time. So just kind of, I suppose, what I described earlier about looking at very specific things, but just going a bit more regular. So so absolutely, the model was set up to support us to do that. Certainly not to not go on site as.
I mean, that's really reassuring, because I wasn't getting that impression from what you were saying. I think perhaps a few of us were concerned about that. So in terms of being able to go more regularly and spend more time there, what sort of, was that one of the aims of changing the system? And if so, what's the desired sort of outcome of that? How many times? How much more? What would the improvement on that be?
So the model was designed for us to work more agile, more flexibly. So absolutely, to be able to visit providers, visit services more regularly, be able to respond to concerns, respond to improvements, and go in and be able to do that, and be able to update the system with that information, so that you kind of reviewing that rating more regular as well.
Can you give me an idea of what more regular means? Because obviously, looking back, there's been obviously a gap during COVID, so that's obviously for that reason has not been regular. So is it to be more regular than has been in the last 5 years, or is it to be twice a year, where it was once a year, or once every 3 years? Just to give us an idea of what to expect.
It's hard to put a kind of time frame on, but I suppose when Melanie said earlier that before we might have said, well, we'll go back and visit a service every so many years, we won't be doing that anymore. And it might be that we've got one provider and we're getting information coming through, positive or negative, it could be any, and we feel like we need to just go and have a look at that, and that might happen a number of times throughout the year. Or it might be that we're having regular discussions with a provider, we're not getting information of concern through, and we've got some improvement things coming through, and we might want to just go look at that, and that might be just once or twice. So it's really, we're just responding to what's coming through to us, what we're hearing from people using services, and from that kind of engagement work we do, so which is not just with the provider, it's with other stakeholders as well. So it might be with local authorities or just different stakeholders. So we're just responding individually to what we're getting through and trying to work flexibly with that.
I was going to say, I think that's probably where I'm slightly concerned, and it might be my lack of understanding of it, because quite often through this you've said about where we get information coming through. So for a service that, say, as you've just described, a small service that doesn't have a lot of relatives involved, that isn't in contact with you, the people who live there, for instance, also can't access you. There's just a bit of a concern around, because you've said quite frequently, if we're getting reports in, and maybe it's just that we haven't fleshed that out about what that means about where else you're getting information from. That's the bit where I feel it's more reactive than proactive.
And I think that part of our system, so behind our system as, you know, as the regulatory platform, we've got a whole data and insight tool model, which gathers information from not just feedback from, you know, various sources, but part of that is that exactly what you're saying, where we haven't heard from you know, about a location for a period of time, where we haven't had any feedback, then that triggers as much as having a lot of information. So it's trying to sort of figure out a balance between, is that right for that service, that we haven't heard anything? And so those triggers, our very clever data team have pulled all of this together. So that's part of the information that we consider. So it's not just information coming in externally. It's part of what we have and what we call our monitoring system. So the assessors, as Joe alluded to, the assessors will do that alongside the regulatory coordinators, continually assess where we've got information that's either from our own systems or where we haven't, and where we need to go out and look at that.
Thank you. I've got one question. You alluded earlier that you would be inspecting all care providers within Kirklees. How far along are you with this? How long do you actually envisage it will actually take? As in, sort of, are we looking at, say, this time next year everybody would have been inspected, or is it sort of a 2-3 year plan?
I think it will be longer than a year. We couldn't really put a time scale on it. I mean, as we've described, there's a lot of services, and we have a finite sort of number of resources to go through this. What we have got going forward is, for each area we're going to have, and Joe's mentioned this, so we will be doing our risk assessments, as we've said, either where we're receiving information about improvements or concerns, but also our planned assessments. So there'll be a number in each area, each year, each month, each quarter, that our teams have to carry out. So as part of that, we'll be able to demonstrate, you know, we've looked at X amount of or X percentage of services across Kirklees. I think without being evasive, which it probably sounds, it's because it's literally so new. We're just rolling out, and we're needing to see how long it's taken for assessments. And at the moment, unfortunately, there's a lot of risk that we're dealing with. So there's a lot of recent inspections where we're taking urgent enforcement action, which is pulling the inspection teams off the more sort of planned assessments. So it's pretty difficult to be able to give an answer. I mean, we can come back, you know, in 6 months and say, this is what we've done, this is the plan. We can do that, but just at the minute, we're just sort of finding our feet in terms of timescales for moving forward.
Thank you. Councillor Addy?
Yeah, so there's quite a long time frames, and a similar kind of question. It included a bit of that. So it's sort of 3 parts on time frames. Where you say you haven't heard from a site as much as you have heard will trigger an inspection. What time frame guarantee can you give on that? What will you be saying? As in the past, people have been expected to be inspected in a certain time frame. As Councillor Lawson has already asked, about these overarching assessments, you said you need those done for the system to be able to work flexibly and be ready to run properly. So I think at some point we do need to know a firm idea of when those are happening. Hearing that there's a lot of assessments taking requiring urgent enforcement action, it is concerning, and I think we'd probably like to see an update on that as well. And then when you talk about the reactive assessments, that come on the back of professional or individual residents, users' concerns, and how quickly you have to react to safeguarding, but there'll be a scale for less immediate things. How well are you doing on meeting the time requirements to meet those assessments responsive to complaints?
Okay,
Thank you.
I think, so on your first point, so in terms of guaranteed timescales, I think you'd said for carrying out the initial assessments, was that your first point, just to, so I'm making sure I'm answering
Sorry.
the right.
The first point was about sites that haven't had specific, or services that haven't had specific complaints, as it were. A lot can happen.
Yes.
A lot can happen in a year, 2 years, but might not have triggered a serious complaint. So, what guarantee are we going to have that those places are going to be reassessed regularly?
I think that's part of all of that is part of our operational decision making. So as we get this information, whether it be from data, whether it be from intelligence, whether it be from our teams, you know, working together as we've said, then we will make a conscious decision through what we call a decision review meeting, in terms of what we prioritise, where we prioritise our resource, where we go to inspect. There isn't sort of a guarantee about when. There isn't a time, we aren't aware of a time scale when we would carry out all of these reviews. We have a national team called the Hub, and their role in part of this is to assign us the planned assessments that we talked about earlier. So every month, as I've said, every quarter, there will be a number of planned assessments across all of the sectors, where our teams will go out and inspect those services. So in terms of timescale, we in our local team don't have a timescale. I couldn't give you that at the moment.
And the other two parts?
Can you just repeat those? Sorry, I was trying to make notes at the time.
Right. You spoke about the fact that the overarching assessments that need doing on all venues, on services, need to be done before the system will run properly. Councillor Lawson was asking about a time frame, but this service will not run properly and flexibly and agile until those are done and in place. So I was saying we do need to have an update, and when will you know when they're going to be done, even if they're not done? And the other part was, how well are you meeting the requirements when you have a complaint? So how are you meeting those timescales? You know, ambulance services have how many times they get to things within a certain period of time. You have 24 hours for safeguarding issues, but you'll have more time for different issues. How well are you doing at meeting those targets for assessment, reactive assessments, please?
So in terms of the system not being able to work quite as flexibly until we've done the full assessment, can't give you a time scale. We're just trying to, I suppose, look at our resources. If we're going out to do risk inspections, which is a lot of our work at the moment, we're doing the whole inspection, because we need to get that up to date rating to then be able to in the future work agilely. So I can't give a time scale of when they'll all be done. We're just working through them. As we inspect services. I suppose in terms of responding to risk, responding to those concerns, we have weekly oversight meetings, sector oversight meetings. So any concerns that are coming through to us, to our assessors, we're discussing them at those weekly meetings, and then deciding if we're going to go out and inspect or if it's something else we need to do. So we're having them weekly meetings. If something comes up that is more urgent than that, as in a safeguarding concern, and we need to go out before we've had chance to have that weekly meeting, then we arrange that very quickly within our local teams.
Thank you, Councillor Addy.
What percentage of those targets are you meeting? So I appreciate that all the time you're constantly getting things in and going out. Yeah. Who checks who's quality's checking the Care Quality Commission? Where are those percentages that say you've managed to meet and go out to these things within the time scale? Because I appreciate you saying you've got a lot of risk management. We're concerned that, you know, if you're doing all that, you're having to put on hold more routine inspections. Are you meeting the needs of those reactive concerns? Are you being able to get out in the timescales that you have defined?
We don't have KPIs for going out on inspection. We have KPIs for responding to safeguarding concerns.
That's what I mean.
But we don't have KPIs for going out on inspection. So we respond when we get the information of concern in. If that requires an inspection, we would respond within usually that would come in, we would arrange a decision review that day and make a decision about whether we're going out or not. But there's no KPI attached to that.
Are you meeting the KPIs on the safeguarding reactions then, please?
Yes, we are. We're meeting our KPIs in terms of safeguardings.
Can I
I mean,
So
I suppose all I was going to add to that is that we get, maybe in terms of assurance, we get access to a data report that we as operation managers can access, and that tells us it'll tell us how many safeguardings we've got in per area, how quickly they were responded to, was it within KPI, wasn't it within KPI, and we're not seeing any kind of concerning pattern around not responding within KPI, I suppose is what I'm trying to say.
Thank you. Can I just go back to the services that aren't sparking off any complaints? You could if you look, say, maybe as a scenario, a small home for adults with learning difficulties that maybe don't have relatives that are coming in on a regular visit, they're not going to be able to flag up complaints or that, but you're actually saying that your system would sort of would raise it with you if there was nothing coming through. What type of time frame are we looking? Are we looking at 6 months, a year, 2 years of nothing coming through that you might actually want to sort of investigate?
I think the system's like an ongoing monitoring system. So we will know from the day from the day they registered what sort of information that we've got in, and that's very much what I was talking about earlier on about our assessors working together. So the assessors will be reviewing the information that we either do or don't get in. We get alerts from our data and insight team. This is part of our new system as well, where we will get an alert, whether it be via email or through our system, from the data and insight, either positively or negatively directing us to look at a specific service because we've either had more information or very little. So it's partly automatically generated and partly through the knowledge of our teams.
It will flag it up, but what I was wondering is how long it would take for it to be flagged up. Because obviously if you inspected something in June, you wouldn't expect, we've had no information in July. But say if you had inspected something in June 2022, but had any information in sort of July 2024, would that be a cause for you to think, hang on, maybe we just need to have a chat with them?
It's an individual service. What works for one service or what we might expect for one service or one type of service isn't necessarily going to be the same. So we get monthly reports. So we would be able to pick up, our teams will be able to pick up from those reports what they're seeing or not seeing. So again, like you say, if you use that example, you're probably going to, if you never get anything, even a couple of months after an inspection, you're going to be thinking, we found this on inspection, we would have expected more than that. So it's about that local knowledge and about expectations from the team.
Thank you. Councillor Addy?
I'm sorry, that I still have a question on this. what's the longest time a site or service will go without an inspection? It may be different for different services or different sites. What is the longest time? Because I have seen care homes in our area supposedly every 3 years and been 5 years down the line, and I know COVID then hit, which meant they were even further down the line. What is the longest time? What will your system say? No, we need to go look. So let's take care homes. Is there a time scale? What is the longest time a care home can go without an inspection?
There isn't, that's what we were saying earlier on, there isn't a sort of a, I can't think of the word I used earlier on, a schedule, there isn't.
There must be a cut-off though, surely. You know, you say it flags things up. When does it say, stop, we haven't had an inspection here? We haven't had an inspection for this type of service after this amount of time. We haven't had, what is the, you know, the programming in the background that's throwing that up, the cookies or whatever they are? I'm not, you know, what is the timescale for them? I mean, surely you know in your heart that you can't leave this sort of service for this length of time. We've got on a programme, the programme must have been programmed to flag things after a certain amount of time. What's the longest time? I mean, if you can't tell us now, maybe you can come back to us with the different services, and this must absolutely come back to us after this amount of time. So we know that there is nobody going to be left without an assessment, especially when there's lots of other things going on that's gone for more than 1, 2, 3 years.
I think we would have to come back to you on that. It's not necessarily, although we as the local teams are heavily involved in monitoring the local services in terms of, you know, national timescales about when we will and won't do or assessments, then that's sort of not out of our remit really. So we'll definitely come back to you on that one if you don't mind. Apologies.
No, thank you.
I think obviously you can tell that I think most of us are quite concerned about the lack of performance indicators or expectations of when inspections will be carried out, and I think that's been driven by it's great that there's all this information that you will hold on a database that's going to build a picture of somewhere, but I'm well aware of the value of an on-site inspection, and I'm also well aware of how documentation, electronic documentation, can be manipulated, and even to the point where you may have feedback from people chosen by a particular establishment that where there has been no objective view of that environment and literally how people are spoken to, and someone checking the medication charts, someone checking that their movement and handling's been done correctly. Without that, and you can't do that just by electronically. I'm sure you have had this concern raised with you from a number of different places, and obviously it's your turn to field those concerns from us today. But essentially that's my biggest worry, is that I understand you've said that you'll be getting information from elsewhere, and you know, maybe I don't fully understand the assessor's role and how much of that information is coming in, but I can only see that there is information can come from the provider, the person who's living there, or their relative, or an inspector. You know, that's essentially, and the local authority will have an input into that, but the local authority are not inspecting independent residential homes, and they're certainly not inspecting any of their own services. You know, that's, you know, we hope that local authority are doing their best. But it's concerning that, maybe I don't understand it, but it does seem that the primary cause to trigger an inspection is, as you've said, an urgent risk inspection where you've had cause for concern, which, yes, I think as Councillor Addy asked, it would be interesting to know how much of that is happening in our area and get some feedback on it, but also that it's coming back from residents or relatives. And again, from experience, it takes a lot certainly for residents and their relatives to potentially upset the apple cart and come to you. So there's usually a lot has happened before that happens.
Yeah.
So that's why I think we're expressing such concern that you, as in Care Quality Commission, not you as individuals, don't have, even for yourself, an expectation of when these inspections will be completed, when we will have, it's highly unusual for us to hear of an organisation of this size that doesn't have that, even as an aim, even as we want to set this for ourselves.
So I suppose I'd just add in there as well that with this change of model, we have what Melanie discussed earlier, we have the hub, and their role is about doing the planned inspections. So they will be the team that will be setting those parameters around planned inspections, but it's not rolling yet. So that's kind of one of the next phases to come, that they will be taking a lead role for those planned inspections.
So they will, sorry to interrupt, but am I right, and just so I get this right, are you saying that there will be parameters set for planned inspections in the future?
Yeah, that will happen in the hub. So in the local teams that myself and Melanie work in, we are responding to risk as risk comes in and setting them inspections. So that's why we can talk about those risk inspections a little bit clearer. But for the planned inspections, they'll be done from the hub that will have that role for planned inspections, and they will set them parameters. But we're not there yet.
Okay, thank you. I didn't understand that was happening. So thank you for that. I appreciate that.
Thank you. Are there any further questions? Yep.
Just a quick question really, and I know this is probably a challenging question, but in terms of your own department, how do you consider the resources that you've got? I'm just interested to know why are some of the changes, I understand all about lean working and it might be more efficient to do less site visits, but is this not partly driven maybe by resources? Because you have alluded to it before about, resources, and I know it's kind of through every organisation it's a challenge, but I'd just be interested if there's a view.
So I suppose at the moment we've just gone through a massive transition.
Right.
And as you're aware, when any organisation goes through such a big transformation, some people decide they want to stay, some people decide they want to move on, and it's the new ways of working.
So it's a restructure, yeah.
So yeah, absolutely. So we have lost staff through that transition period, people who've not wanted to stay and work within the new model, people who were unsure what that would look like, and so that happens anywhere when you go
of course,
that.
yeah.
But we know as an organisation we've lost people, so we're recruiting, and we've been recruiting since we started this process. Yeah. We've got new people starting with us all the time in the teams. We're on a rolling programme of recruitment. So
recruitment's not an issue. I'm just worried that some of the changes have been partly driven by resource. And I know obviously that can be a contribution, but the extent of it really, the big move from less on-site visits, obviously it's quick and easier to do online and concentrate maybe on some quality statements rather than do a full site visit.
It was never the driver. The resources was never the driver for the changing model. That was very clearly.
That's good to know. That's good.
Within the commission before we started that transition process and the work on the new model. But because of the transition, we have lost people because that's just a normal part of that process. But yeah, we are on recruiting all the time, and I suppose that, you know, until we're at full capacity within teams, there is going to be a resource issue. That's a normal thing, but we are working to recruit and get that full capacity. There's all the teams were modelled in terms of the new model of who we'd need in each team to be able to provide a full complement of staff. So we're still working towards that with the recruitment, and that will be reviewed. That's something that's going to be reviewed as we go along to check that modelling is still a true picture.
And I think if I could just really emphasise that the on-site inspection is still a huge part of what we're going to do. The remote stuff is to really complement that and give us the flexibility where we don't necessarily, you know, if it's about a particular issue that we don't need to go on site. I suppose I don't want to leave the impression that we're not going to go out, because we are, and in the future we'll be going out more regular, but the on-site inspection is a huge key part of what we're doing. So I just want to emphasise that.
Okay, thank you.
Thank you.
Councillor Addy.
So we really appreciate the important work that the Care Quality Commission does. So don't get us wrong, we're just always very anxious to make sure we've heard everything that we need to ask questions on. It's such an important thing to keep an eye on things and respond to things. You've reported to us today that you've got so many risk inspections and urgent enforcement action that's been holding up the overall assessment. So that is something that I would like, and I'm sure that the panel would like you to come back with us some update on that in, I look to the chair, 3 months? 6 months. Because you can compare then, you know, these are coming in now and maybe that might have subsided, you'll got on top of that, you'll have taken the action and hopefully they'll have responded. And also you may need to refer us to the hub or put somebody on with you from the hub on these timescales for the longest period of time that a setting or service is going to go without inspection. I know you said you couldn't say that off the cuff, so if perhaps they could come back at the same time, either with you or with you, give you the information to bring, that would be much appreciated. Yeah. Thank you.
Thank you. Are there any further questions?
Just one quick note that I just wanted to mention. When we looked at the reports for adult social care on the other document, we said that I just wanted to sort of note that Kirklees does seem to be worse than the national ratings, in that we've got half as many expected in outstanding and we've got more in requires improvement. So it was just I know we sort of said that there was 73% in good as opposed to nationally 78%, but we do have quite a large chunk that seems to me quite a large chunk of being not as good, it requires improvement and not enough outstanding. I just wanted to clarify that, you know, obviously we would hope, as I think all of us would, that those ratings improve over the coming year.
Yeah.
Thank you.
Thank you. Are there any further questions? No. Thank you. Can I just thank Melanie and Joe, thank you for attending the meeting with us today and obviously giving us a good overview of how the new assessment model will be working. As Councillor Addy said, it would be good at some stage in the future if we could just have the answers to the questions that were actually raised regarding sort of the bigger assessments, so that you can then move on to sort of using the new model better. But thank you.
Thank you for your time, everybody.
Thank you.
Thank you. Bye.
we can move on to the next item on the agenda, which is the work programme. No, you can stay. Is looking at that is one thing that we have had a reply to from yes, Councillor Armour asked questions regarding around the dental service, but unfortunately there didn't appear to be anybody that could answer them, so I think we should be in agreement to maybe actually adding that to the work programme. Yes. Yep.
Yes, I agree with that.
What's our next meeting? And is for the August meeting, we're going to be looking at the joined up hospital services and the mental health and well-being. We've obviously in the pre-meeting gone through what we'd like the mental health services to actually look at and come back with us. Is there anything further on that discussion that we had that you'd like to actually add to that item? So we're going to have joined up hospital services, and we're also going to have mental health and well-being. At the pre-meeting, we did go through what we felt that they wanted to look at. What I just wanted to know if there was anything else that you wanted adding.
No, I think we had a comprehensive chat about that.
Yep. And if you've actually looked through the work programme, is there anything else that you feel that we should be discussing within the next year? Councillor Addy.
Are we going to get an update on maternity services? Are we expecting one anyway, and it's going to come along?
Because we actually referred maternity services to the JOSC, which is under the Calderdale and Kirklees, Josh, is they actually came to that meeting, which was a couple of weeks back. And what I have actually said to people is you can actually see the webcast on there, and they were very informative with sort of what they, obviously it's just been about a month or so the figures that they had, but is they'd gone through sort of how many people women they'd had to refer to Pinderfields, how quick it had actually taken ambulance services to come through, and obviously they then look at is why that person was referred, was it the correct decision, and on all occasions it actually was. So I would refer people to that webcast there, but we have also got I think it's on in January, an update from all the JOS that we've got, which would include maternity services, the looking at the joint Wakefield Calderdale one for sort of patients with dementia and where they would figure in the mental health services.
Hello, thank you. Can I just come in on this? Yeah, I think at our pre-meeting, the previous pre-meeting, we discussed how, I think I said I'd like to understand the stats around the birth rates. And I think that was something that was going to be brought back to us in relation to maternity services. Are we going to get that information? Do you know? Is that going to be included in that item on the maternity update in January with the JOSC?
We could actually is when it comes from being from a JOSC, it tends to be the officers that would actually report, not the actual service provider. But we could maybe ask for that. Are you looking specifically at sort of birth rates at Calderdale in the medical, sort of the maternity, the midwife-led units, the consultant-led units, and also the standalone?
Yeah, and also where the women who are giving birth, which are they coming from? Huddersfield? Are they from Halifax postcodes? Are they from Huddersfield postcodes? Are they from Dewsbury postcodes? Just so we get an idea, because clearly the birth rate is going to be driving a lot of what's happening in maternity units. So I think it's important for us to understand that. Thank you.
The only thing that we've actually got there, because we've actually referred this on, it's not sort of under our jurisdiction.
Right.
But what we could do is I'm quite willing to actually raise that at the next Josh meeting and just ask if we could actually have that. And then we could, is when we get the report back in January, we may be able to have those actual figures.
So the things that we were asking on the work plan, will we get answers to those from JOSC? Is that the right place that we're getting the, because we've got a number of notes there about things that we want to know. Is that where we'll get that information from? Or if not, we need to work out who it is.
Yeah, the JOSC has got their work programme, and what you're discussing now is all on their work programme in this year. So it's been referred to the JOSC, so they are referring it. Now you can ask for a feedback, which we have done from the JOSC, and it'll be a feedback from the officer, and it'll be to note. It won't be a question session, it'll just be information back from that. It's now with the JOSC, so it's up to them to be asking all these types of questions.
Just on the previous item that we've got, it's just reminded me, on the information that they gave about the inspections, it just referred to Huddersfield Royal Infirmary, and I felt that we probably need to include Calderdale in that. It says the Huddersfield and Calderdale Trust, but it only seemed to report on Huddersfield, and obviously because maternity services are being provided from Halifax, it would be helpful to have that information on. If
I can just answer that, when they actually inspect, they inspect the trust, so they could come to a certain service that may be based in Halifax, but it would be CHFT.
But on the thing it says specifically Huddersfield Royal Infirmary.
But
Sorry, Chair.
is both Calderdale and Huddersfield at that last inspection were actually inspected together. I think they've probably done that because we're Kirklees, and they've just thought is when they do it is a trust-wide thing that they would actually do.
Can I just say, now it's with the JOSC, it's up to them to scrutinise it. If you've got any concerns, you can refer it to the JOSC. So if you've got any concerns, if you let me know, and I'll liaise with the officer for the JOSC. Thank you.
I guess those are our concerns, aren't we? Is that what we agreed in the work plan? Those are our concerns. I think we had this discussion in the work planning meeting, didn't we? That it was. I didn't understand what role JOSC had. But I think we were keen not to completely let go of that, although is that what we should expect to do, is to let go of this to JOSC? And not, yes, you're nodding.
Yeah, the JOSC will do all that. Like we said, we can have a feedback. That's why we've got on the programme, the JOSC's feedback from the JOSCs. It will be the officer that does the feedback to you. It will be for you to note. It's not going to be a questions to the officer sort of thing. But you've asked for an update from each area of those 3 JOSCs, right, and you will get a note back, and it's up to them, the JOSCs, to look at all the concerns. But if you do have concerns, just feed them through me and I will feed them back. But like we said, it's the JOSCs that will deal with it now.
Thank you.
And just for note, is in our informal meetings, I am a member of that JOSC, and if there is anything pertinent that's relating to the maternity services, I will, as I did earlier, is update, point you into the right direction as to where the webcast was, so you could see the full presentation. Are there any further questions? I shall close the meeting.
Thank you.